Good morning. So it's good to see a lot of friendly faces, and it's good to see so many people actually able to come today to attend the meeting, and it's our pleasure to present to you more of, or answering more of your questions. Although some of these slides may sound very scientific, but what I will try to do is to try to keep it simple language for you. Don't worry about exactly what is written in the slides, but I'll try to summarize them in an easier way for you to understand. I'm a cardiologist, so most of the medical therapy that I'm going to be talking about is focused on aortic disease. Doesn't mean that Marfan patients don't suffer from other ailments that can affect, like joint disease, for instance. I'll not be focusing so much on what is the medical therapy that's available for joint disease, for instance, because we don't have any medical therapies directly available for joint disease. Most of the times we treat them with maybe Atenolol or NSAIDs or any one of those things, which are fairly general type of medical treatments, but not specifically targeted towards Marfan syndrome, because we don't have any at this point. But I'm going to focus primarily on talking about the aortic disease itself. Just a brief review. Melinda's already covered that. Marfan syndrome, as all of you know, and most of you suffer from it. It's a connective tissue disorder caused by mutations in the fibrillin gene. It has multiple different manifestations of it. As we talked about, it's an autosomal dominant disease, and about 25% of patients can get it based on a de novo mutation, which means that the parents don't have any family history of Marfan's. The three primary areas of concern that we, from a cardiology standpoint, what we deal with mostly is aortic aneurysms. Of course, there are a lot of eye manifestations of the disease, which is considered as one of the main manifestations also of ectopia lentis, and there is disproportionate long bone growth. So those are probably the main features that most people can identify with Marfan syndrome. Incidence, as we talked about, estimated about 2 to 3 per 10,000. The diagnostic criteria were revised in 2010 based on previous studies. This is probably the second or third iteration looking at, what are the factors that really can identify the disease in a certain individual if they have Marfan syndrome or not. And two important features came out of that, one being ectopia lentis, the other one being aortic dilation. So the main branch point with regards to diagnosis is, do you have a family history of Marfan syndrome? Or if you don't have a family history of Marfan syndromes, and how do we identify if you have it or not? That starts with the family history first. So if you have no family history, there are multiple different levels that you have to go through to determine if somebody has Marfan syndrome. If you have an aortic root involvement in a pediatric patient, a Z-score more than 2, or if you have a history of dissection and you've been diagnosed as having an ectopia lentis, those two features alone will clinch the diagnosis that you have a Marfan syndrome. Then you go next step. If you don't have either of those, then you look for other additional evidence. Since we have identified the mutation that actually causes Marfan syndrome, we can actually do genetic testing looking for that now, which is more sophisticated than what it used to be maybe 10, 15 years ago or so. So if you have an aortic involvement and we test you with a genetic mutation, and you have a mutation in fibrillin gene, which is a disease-causing mutation, there are a lot of mutations which are variants of unknown significance, which Christina will talk to you guys later today. If you have one of the two of those features, then that leads to a diagnosis of Marfan syndrome. Or if you have aortic involvement, but you do not have either ectopia lentis or don't have the mutation, then you got to look for what are the other systemic features. And that also has gone through some iteration. And now I'll show you in the next few slides about what are the criteria that we really look for with regards to systemic scoring. Then I should have to credit the National Marfan Foundation webpage, which gives us the diagnostic criteria. I actually hold it on my phone and actually review it with the patient, going through them so that they understand what we're actually looking for. So if you have a systemic score of more than 7, then that, along with the aortic dilation, that also clinches the diagnosis of Marfan syndrome. Or if you don't have any aortic involvement, but you have ectopia lentis, and you have a fibrillin mutation, then that also helps in diagnosing Marfan syndrome. So that's in the non-family history-based patients. How about in the presence of family history? If you have a family history of Marfan syndrome, if you have any one of these features, if you have ectopia lentis, or if you have an aortic involvement with the Z-score more than 2, or more than 3 and over age 20, or if you have a systemic score more than 7, that clinches the diagnosis of Marfan syndrome. So these are some of the systemic scoring system. I don't want to go into too much detail with this, but I think National Marfan Foundation has a page which kind of goes through all of these, and they have actually pictures of each one of these criteria. So what we're looking for, some of the skeletal features, we are looking at some of the bone features, we're looking at some of the imaging features. Those are all the things that we look for. Wrist and thumb sign, most of you, when you go to the doctor, particularly the Marfan patient, they all tell you to do, what is the wrist sign, what's the thumb sign, right? So we do all of those things. And depending on the different signs, you can get a scoring system. We also look at chest bone deformity, pectus excavatum, which is more sunken chest or a pigeon chest. We look at those. Some of them are very specific for diagnosis. We also look at foot deformities. We also look at angulation of your elbows. There are a lot of these bone features that are characterized in Marfan syndrome because of the long bone growth. You tend to have these kinds of symptoms. Sometimes it's a lung manifestation. Somebody had they had a collapsed lung, which did not, happen. It happened suddenly, out of the blue, not related to injury. We call that spontaneous pneumothorax. And so that, again, it helps as one of the systemic features to keep in mind. One of the things that actually got excluded from this was, previously people used to measure the arm span, right? How many of you remember that? So it's not found to be that specific anymore. So even though we use that in the systemic scoring, but it doesn't really add any points when you're calculating your score. So that's one of the things that has gone off of the criteria list there. So when you add all of these things together, if you have a score more than 7 out of a possible 20 points, that clues you into thinking about Marfan syndrome. So that's an important thing to keep in mind. So how about, this probably I think has a lot more relevance in my opinion, more so than the medication. So activity restrictions. So what are the things that I can do? What are the things I should not do? Or what are the things that I cannot do? So that's why I want to spend a few minutes looking at the slides of, what are the activities that you can do. So you should not engage in contact sports. You should not engage in competitive athletics, or you should not engage in isometric exercise. Anything that makes you do, no, you should not do that. Anything that makes you breath hold, that you have to lift a heavy weight, it raises your blood pressure very high, so that's an exercise you should avoid doing. So that's across the board. Moderate, low impact aerobic activity is always encouraged in every patient, not just Marfan patients, but everybody else. Because one of the things, as Melinda's pointed out with regards to the future, we are now almost have a normal life expectancy for most Marfan patients because we have taken care of the most serious complications with the aortic disease. Most patients are able to live a normal life. But that doesn't mean that they are not getting chronic diseases in them. So I have patients who have developed high blood pressure, diabetes, high cholesterol, cardiovascular disease. So even though we conquered what the mutation is causing as a damage, but we still have to be cognizant of what could happen to you as you grow older. So aerobic exercise is a very important thing, and it definitely should be maintained in every patient, whether you have Marfan or you don't have Marfan syndrome. So for competitive athletics, for patients with, who have children, who are young adults, who are looking at what are the recommendations for sports, what are the recommendations for the kids that they can do. So ACCHA has come up with some guidelines back in 2015. So it's a pretty big document which kind of covers multiple other cardiovascular diseases, but I try to focus on the Marfan syndrome itself. So this is an important slide to keep in mind where they looked at what are the different types of activities that you do, and how does it relate to what happens to your heart rate, and what happens to your blood pressure when you do different types of exercises. If you look at this here, if you go along the x-axis towards your right, there you tend to increase your heart output. It tends to increase your heart rate and all of that. If you go up on the y-axis up to the top, that raises your blood pressure a lot because you're trying to lift a lot of heavy things. So if you have Marfan syndrome, these are some of the important guidelines that I can draw from that particular slide there. So athletes with Marfan syndrome should not participate in any competitive sports that involve intense physical exertion or a potential for body collision. So that's an important thing to keep in mind. No football, okay? But soccer, they're all contact sports. You got to be careful about that. Athletes with Marfan can participate in low and moderate static or low dynamic competitive sports if they do not have any other disease manifestation, like you talk about aortic root dilatation, moderate to severe mitral valve regurgitation, or if you have a heart muscle dysfunction, what's so-called left ventricular dysfunction. Family history of dissection are smaller sizes, below the diameter of 5 centimeters, where we recommend now at surgery. Or if you have aneurysms anywhere else, if you had aneurysms in the arteries that goes to your brain, or if aneurysms in the pelvic vessels are down in your legs, if you have any of those manifestations, then we would avoid, even in the low and moderate kind of exercise. Burst exertion, sprinting, yes?
I just want to mention one thing. The foundation, Marfan Foundation, also has
Yes.
And so they were just updated last year, so I highly recommend that you go to marfan.org and check out the physical activity guidelines. They were just updated with Dr. Alabama.
Yeah.
I just wanted to.
Yeah, thank you. And actually, Dr. Braverman's talk is actually on the website also from this year's conference in Atlanta. So if somebody wants to view the video, I'm sure that'll be quite useful for it. So most of these guidelines are taken from Marfan Foundation and also from the American Heart Association guidelines. So burst exertion or sprinting should be avoided. Again, we talked about the static or isometric exertion. Most recreational sports you can do. I think the best things that I can recommend for most patients is swimming or jogging. Preferable to non-competitive sports like football, basketball, tennis. They require a lot of intense rapid acceleration and decelerations. We want you to avoid doing some of those exercises. So that's what I wanted to talk about from an activity standpoint. But most of our management in Marfan syndrome is usually geared towards preventing aortic complications because that has got a long time risk. If something were to happen, then you're stuck with an aortic dissection that requires a lifelong maintenance. But our goal is to prevent you from having that in the first place, and what medical therapy plays a role in something like that is the focus. If you look at this is where we are with regards to where, as we understand the disease as of now. So you've got a mutation in the fibrillin gene. There's an abnormal or reduced fibrillin, which leads to structural weakness in the aortic wall. And also we've recognized off late that there's an increase in some of the other protein signaling called TGF-beta, which leads to vascular remodeling. So there are multiple different factors that are looked in as to what could be the targets for treatment. So as things stand, on the upper right-hand corner, which mentions about ARB, which is the angiotensin receptor blocker, a lot of data came out about Losartan. I'm going to talk about that in the next few slides. But what has been used for a very long time before that is in the left lower corner, which are the beta blockers, which a lot of people may be aware of that, and have been taking those medications for quite a few years. So beta blockers are still considered a standard of care. Most patients, we start with a beta blocker. And it's been there for many, many decades now. I remember Dr. Peretz he's now at the University of Pennsylvania, used to talk about how he would make the patients go run up and down the stairs when they come for the office visit. They put on beta blockers, he makes them run up and down the stairs and sees if their heart rates are going up rapidly or not. If they're going rapidly, more dose added to them. So they're not effectively beta blocked yet. So that's how they used to determine some of the dosage considerations. And some of the trials, if we show you, this was one of the trials, one of the first trials where they looked at using beta blockers in patients with Marfan syndrome. At that time, we used to have very small numbers of patients. In this one, they had about 60-odd, 70-odd patients, and they used pretty high doses of propranolol was used at that time. The average dose of propranolol in the trial was about 212 milligrams, which is a pretty big dose of propranolol. So that's how much of the dose that is used for a beta blocker dosage in the previous trials. And then this was a randomized trial where they looked at patients who were treated with the beta blocker and without beta blocker, and this showed that patients who were treated with beta blocker had a lower rate of aortic growth. So that's a big message to take away from that. So forget about all the other things. So the dose was used to titrate to keep your heart rate under 100 during low impact exercise. So it means that they had to give them such high doses to make sure that their heart rate doesn't rise rapidly when they did exercise. So that was the idea behind using high doses of beta blockers. And then came along more trials, more data looking at, I think the biggest thing that Dr. Dietz's lab has done is to develop a mouse model of Marfan. That really helped in revolutionizing a lot of the care where they could test a lot of different things in animal models before they could actually try them in humans. And most models have shown actually that angiotensin really plays a big role in the abnormal protein called TGF-beta signaling, which leads to the aortic disease manifestations. So that's where this next few things came about from Jen Habarshi and in Hal Dietz's lab. And they decided to test all of these things. So this is one trial looking at what we call as an ACE inhibitor, perindopril. People have heard about lisinopril, enalapril, and all of those things. So they're all considered as ACE inhibitors. And those are some of the medications that have been tried in Marfan syndrome patients before the Losartan one. This is a small trial that's published in Australia where they looked at 17 patients with Marfan syndrome. And they found that it is pretty effective in preventing the aortic root from growing further. So this led to more trials looking at, now we have more data about TGF-beta signaling, so they looked at angiotensin receptor blocker. So the animal models really showed a dramatic reduction in the growth of aortic root. So they decided to test that in humans. This was a small trial where they looked at about 18 pediatric patients. And in this one, they found that the aortic root did not grow very much if they used Losartan. But this was more an observational trial, which is not a real true experiment where you give one medication to a certain group and the other group did not get the medication. So then they had to go to the next level. And that's where they devised the angiotensin receptor trial. This is from the first paper with the pediatric patients. You can see here at the level of the aortic root, on the left-hand corner, the taller bar is the one who did not have Losartan, and the shorter bar is with Losartan. So the aortic root growth was tremendously stunted when patients got Losartan. So this was very exciting. Everybody thought that only beta blockers are the only medications you could use, so Losartan is like this dream come true for a lot of people. But we had to test it really. So there are a few trials which looked at how about if we add the Losartan to patients already taking beta blockers. So this is a trial that was published from Thailand where they looked at addition of Losartan to beta blocker therapy. Again, this was a non-randomized study. And in that, they again found that if you add the beta blocker Losartan, and if you look at the yellow line on top, it's only grew about 0.1 millimeters compared to somebody who was not on medication, it grew a little bit larger, a little bit faster. Again, more encouraging signs. So next one was, this was done in, I think it's a Netherlands trial, where they looked at Losartan again in addition to beta blockers, and they found that in their group, they didn't really find that great of an endpoint of addition of Losartan was really. So there's becoming some mixed messages now begin to show up. And now this was the bigger trial that the National Marfan Foundation was involved in, where they looked at Dr. Lacroix and colleagues from Boston had done this, Atenolol versus Losartan in children and young adults with Marfan syndrome. So here's a true comparison. So they said, okay, we are going to take a group of people, we're going to give them Losartan, or we're going to give them a beta blocker, and let's see how they're going to do. So at the end of the trial, the results of the trial was a little bit surprising because Losartan didn't really show that it had the same effect that was seen in the smaller mouse models or smaller trials that were done before. So this was come as a bit of a disappointment for the community who have been doing this work for quite some time. So this had about 608 participants, one of the largest trials looking at, a randomized trial looking at Marfan syndrome with, for medical therapy. In this one, they found that among children and young adults with Marfans who were randomly assigned to Losartan or Atenolol, they did not find a big difference between Atenolol versus Losartan. I think what they're expecting going into the trial was that Losartan is going to have a dramatic effect compared to the beta blocker, so that they could find something which is a great agent to be used in every patient who has Marfans. And I'm sure a lot of people can relate to being on a very high dose of beta blocker and having side effects of the beta blockers, right? Anybody? There are a lot of patients who complain about, particularly young adults, complain about being on a very high doses of beta blockers and how does make them feel groggy and tired all the time. So everybody were looking forward to something new, but unfortunately the trial didn't really show that Losartan has the dramatic effect compared to taking an Atenolol. This is a big thing that take away from that one. So what are the limitations? So what do they not include, and why these results didn't come out the way they thought it was going to come out? So they also did not check whether the Losartan dose that they used really lowered the TGF-beta levels, because that's what it is targeting, right? It's an abnormal protein. If you had a dramatic reduction in the TGF-beta levels, maybe you would have had a better effect. Maybe the dose of Losartan that was used in this one may not have been the correct dose. They went by what they already knew. So it's possible that maybe a different dosage could have yielded a different result. So that's one of the limitations. And then they also took patients who had a very large aorta right at the beginning of the trial. So how about if you start the medication at a smaller size aorta? Would that have a bigger effect? Would that have made the aorta not grow as much? So those are some of the limitations. How about they took the dose of Atenolol that was used in this trial was substantially higher than what it's been tried before in other trials. So could we have made the beta blocker look more efficient before even the trial was completed, because we have used a much higher dose compared to the Losartan? So there are a lot of these different things in the community talking about what could have led to the results that they got at the end of the trial. But the bottom line is that's what they got. So that's what we go at this point in time. So how about some of the other trials? These are all done in the US. How about some of the trials which was published? This was a trial that was done in the French group, where they looked at comparison of Losartan versus a beta blocker. And then they used, Losartan 50 milligrams when they're less than 50 kilos, or 100 milligrams otherwise. Again, this is what the established doses. They haven't used any higher doses. In this trial, again, it was able to decrease the blood pressure, which is used as a blood pressure agent, but they really did not find that the aortic dilatation was really not that much different in patients who were using Losartan compared to the beta blocker. So they came to the conclusion that should not be, like if you have a Marfan syndrome, Losartan should not be the first drug that we should be giving you. Losartan can be used as an alternative if you were to be not tolerating the beta blockers as much. So that's where we are. But the evidence is more evidence is going to come out where they're testing this in other groups, in other areas. These are all the different trials that are ongoing right now as we speak in different countries. So this is a UK AIMS trial where they're looking at not Losartan, but a cousin of Losartan called Irbesartan. And they're looking at a randomized trial across England, Scotland, Wales, and Northern Ireland. They're looking at if you're taking Irbesartan versus placebo on top of a beta blocker, which you're already taking, would that have any effect? They have enrolled up to 202 patients. The trial is going to end in March of 2018. So sometime next year, we will get some results from this trial to see if there is any effect, any differential effect, I should say, from Irbesartan to Losartan compared to adding on top of a beta blocker. Some of the other trials that are going on. In Belgium, there's a trial called the Ghent Marfan trial where they're checking Losartan versus placebo again in patients who are already on a beta blocker. They also checking this, and I don't remember the exact country where they're doing this, but they're comparing Losartan versus one of the newer beta blockers called Nebivolol or Bistolic. So that's the brand name for that. So they are testing that compared to, it's actually three groups. They're testing Nebivolol isolated, or they're testing Losartan, or the combination of two medications in patients who've got genotype Marfan patients. And there's an Oxford Marfan trial where they're looking at Irbesartan again, along with doxycycline. Do you remember that slide that I showed you, which had increased matrix metalloproteinases? These are all the abnormal proteins. So doxycycline, which is an antibiotic, which is a tetracycline, has been shown in laboratory experiments that actually has a very good effect on decreasing the levels of matrix metalloproteinases. So they're trying to extend that concept in humans by actually trying out the medication and then see if that makes a difference to patients with Marfan syndrome. So that again is I didn't get much detail whether they're enrolling patients or not, but that's one of the trials that's up and running at this point. And there is a Marfan trialist collaboration. This is a big group out of Oxford where they're trying to pull together all these multiple different trials from across all the continents and then come up with some, when you have a large number of patients and you look at the data with regards to what treatments have worked and what treatments have not worked, it can give you a signal as to what is actually working and what should we be giving or treating patients with Marfan syndrome when we combine all of these data. So as things stand, these are the recommendations for blood pressure control in Marfan patients. So beta blockers should be the first choice to all patients with Marfan syndrome and aortic aneurysm to reduce the rate of aortic dilatation unless they have a contraindication to it. So beta blocker is the first line therapy. You can consider Losartan is reasonable for patients with Marfan to reduce the rate of dilatation unless, let's say somebody who cannot completely tolerate being on a beta blocker, they have severe side effects, then Losartan is definitely a very good choice for you. These are the other medical therapies we talked about. So doxycycline is the one that is a non-specific matrix metalloproteinase inhibitor. Animal models have actually showed that there is slowing of the elastin degradation in the mouse models. And they have used this in a small sub-series of human patients with abdominal aneurysms. And they actually found that it slowed the rate of progression of the abdominal aneurysms. There's another antibiotic called roxithromycin. It's an analog of azithromycin or erythromycin that also has shown in a very small trial limiting the rate of abdominal aortic aneurysm growth in humans. So how about statins? Statin medications as a direct or primary treatment for Marfan syndrome per se, not as a treatment of high cholesterol, but can be used statins directly just to treat as Marfan syndrome. There was one of these mouse models which looked at, again, pravastatin reduced dilation of the aorta in these mouse models that they have looked at. So in this, they said significantly, if the aortic root diameters in untreated Marfan mice have significantly increased compared to the mice that were treated with pravastatin. I have not routinely used in every patient, but if they have had manifestations where they come in for surgery and we did a coronary angiogram and they've got a plaque, then I've been routinely using statins in those patients. So one of the other interesting ones that we are sometimes careful about not putting people on amlodipine. Again, it's based on very, very, very small Again, mouse models, is it really going to pan out in humans or not? We don't know. But amlodipine seems to increase the rate of aortic growth. Again, this is really a stretch. If I have to, use this in a human patient and say, we should not be putting an amlodipine because on a very small mouse model, because as we've seen with Losartan, the dramatic results from mouse models cannot sometimes be replicated in humans. So we just have to be careful about that. So that's some literature about how about therapy after surgery. People assume that, I had aortic root surgery. Do I still need to take a medication? Yes, you still need to take a medication because aortic dissection and branch vessel aneurysms and dissections can still happen. So it's important that you stay on a beta blocker even after surgery. And beta blockers and angiotensin receptor blockers should be continued even after you had an aortic root surgery to prevent the risk of dissection happening in other parts of the aorta. The other thing that we also have to keep in mind is there are multiple other cardiovascular manifestations, not just the aorta itself. Patients can have mitral valve prolapse. We talked about that. Mitral valve prolapse, mitral regurgitation. People sometimes get a cardiomyopathy. So cardiomyopathy is where the heart wall doesn't contract as well, and patients can end up with congestive heart failure symptoms. So in those situations, we still need to treat them with more medications than just beta blockers alone. So ACE inhibitors play a big role in that. There are newer medications that are being discovered all the time with regards to cardiomyopathy. So that's another important thing. How about antibiotic prophylaxis? And how many times do you get calls about patients having prior surgery with either a valve or with a graft? They should take antibiotics before dental cleaning to reduce the risk of having infection related to endocarditis. So that's an important thing to keep in mind in patients who have had prior surgery. So take-home points, medical therapy plays an important role in patients with Marfan syndrome. Beta blockers and angiotensin receptor blockers are the mainstay of medical therapy. But as I mentioned previously, as patients live more normal lives, the chronic diseases like hypertension or diabetes tend to happen. So most average Americans need at least 3 or 4 medications to control blood pressure adequately. So if you have maxed out on both the beta blockers and ARBs in a Marfan patient, you may have to use other medications to get their blood pressure under better control. Then you may have to use amlodipine or you may have to use any of the other medications. I'm not saying that when you reach the maximum, no more, we cannot give any other medications. That's not true. As people are living more normal lives, they may need other medications to be added on top of, but these should be the primary medical treatments that we should be using in all patients with Marfan syndrome. Multiple trials, as I said, are ongoing to clarify further the role of angiotensin receptor blockers. There are other novel therapies always coming up, and we will keep testing them. So if you go into the National Marfan Foundation, the amount of grants that they have donated money for this year, most of that is related to looking at more genetic type manifestations and how we can use them as targets for future medical treatments. Activity restrictions, it's a key part of medical treatment in all patients. What can I do, what shouldn't I do, and it's very, very careful. You should be aware of that. So I'll leave it at that, and if you have any questions, I'll be happy to answer them.